All right. Good evening, everyone. So my name is Robert Fahed. I work at the Ottawa Hospital, 4 hours east of here, 4 hours drive. I'm an interventional neuroradiologist and a stroke neurologist. I joined this wonderful country 3 years ago. And before that, I used to work in Rothschild Foundation Hospital in Paris. Absolutely, I work with Michel Cotin. We're being recorded. Yeah, I work with Michel Cotin. Michel, if you can hear me. Yeah. I worked there, and so I had the honor of being part of Aster 1 and Aster 2 trial. I'll talk about them today. But basically, we were very interested in trying to determine which technique is best for thrombectomy, stent retriever, aspiration, or both. And I was very, very lucky to be part of those two trials. And I would like to share some experience with you about all this and why I think the BDAC has should be on the shelf of everyone who's trying to do EVT. So if you look at the very recent history of thrombectomy, you'll clearly see, and everybody saw that even though we had benefits with Mr. Clean 7 years ago already, our success rates only got bigger and bigger. Mr. Clean only had a rate of successful recanalization of 58.7%. And the latest one, which was published only a couple of days ago, Swift Direct, we're above 90%. So nowadays, we can say, without showing off, we recanalize basically everyone, because those 7.5% that we can recanalize, they're not clots. They're very often ICAD, they're very often very particular subtypes of clots or very dry clots. But most of the clots do not resist us anymore. So the quest for the highest rate of recanalization is over already. We're already there. What we're trying to do is go beyond this. What we're trying to do is getting a home run each and every time. So Dr. Zaidat published a couple of years ago, and I think that was a genius move, a new metric that he called the first pass effect. The first pass effect, as everybody knows, is the home run. It's you completely recanalize the patient. You leave little to no distal clots on one pass with nothing else. Basically, you're in, you're out. That's the perfect game. And as it was shown in the initial paper, when you can achieve a first pass effect, you have higher chances of good outcome, lower risk of mortality, faster procedure, safer procedure. Okay, so it's like all benefits for the patient and for the physician. A couple of years later, that's something I published. We also showed that the first pass effect is also meaningful in basilar artery occlusions. So regardless of the occlusion site, anterior circulation or posterior circulation, if you can achieve a first pass effect, it's all for the best for the patients. So that's what we should aim for, okay? That's what we should try to achieve, because this is currently only achieved in a small fraction of patients, and this translates into better outcomes for the patients. Now, how do we get that? As you know, we have three ways of treating patients. We have stent retriever, contact aspiration, and Solumbra combined approach, call it the way you want. And how do these techniques behave in terms of first pass effect? Well, I was talking about Aster 1 and Aster 2. Aster 1 did not report the rates of first pass effect, but I published a sub-paper of Aster 1 which reported those rates, and it's published in JNIS, by the way, and Aster 2 reported the rates of first pass effect. So here is what we notice. There is a trend to do slightly better with a combined approach as opposed to contact aspiration or stent retriever alone, although it's not statistically significantly different. But what you can see is there is a lot of room for improvement, because that home run I was just describing, we're not achieving it in not even half of the patients. And that means that from a statistical, scientific point of view, there is a lot of room for improvement. And this is where we can try to achieve better outcomes in terms of trials without having to enroll thousands and thousands of patients. So that's a great surrogate marker. That's a great surrogate endpoint. And it immediately translates into better outcomes for patients. So it's a meaningful endpoint to try to improve. Now, how do we do this? First of all, there is a question of the balloon guiding catheter. My friend, this one is for you. So you're going to love this, trust me. Should we use it? Yes or no? For stent retriever, I think it's pretty obvious that it would be hard to justify doing a stent retriever only technique. I'm not mentioning any contact aspiration catheter, stent retriever only technique without a balloon guiding catheter. Long sheath plus stent retriever technique is, I think, hard to defend in practice, and I don't know many people who do it. Excuse me? Do you know anyone? No, me neither. That's what I'm saying. I think if you go for stent retriever alone, and the evidence is pretty compelling, you need a balloon guiding catheter. Now, the downside when you do this is, if you don't have an intermediate catheter, the only support you have is at the neck level. balloon guiding catheters historically are not providing as much support as the long sheath. And so you're left alone with your microcatheter to try to go across the clot, which is not necessarily easy. For aspiration, the benefit is uncertain. We currently do not know if inflating a balloon guiding catheter at the neck improves the performance of contact aspiration intracranial. We do not have a randomized trial, and we do not even have large cohort studies with not too many biases to actually answer that question. But one of the main obstacles until the very recent generation of balloon guiding catheter was that the old generation catheters, the Flowgate, the Mercy, etc., were not compatible with the newest generation of aspiration catheter. And you were mentioning superbore catheters. It's even worse now. Because if you want to go beyond the Sophia Plus, for example, you don't have a balloon guiding catheter that is necessarily easily compatible. And even if you want to go with a balloon guiding catheter for contact aspiration technique, the problem is the balloon guiding catheters usually do not provide as much support as the long sheath, right? So you're trying to push a big aspiration catheter up there, but the support that you have with your balloon guiding catheter is not as good as the long sheath. Now, if you go combine, technically, you're supposed to use the balloon guiding catheter. And here is why. I mentioned that I was part of ASTER 2. ASTER 2 was negative, okay? The combined approach was not shown to be better than a stent retriever. But what a lot of people seem to forget is that in ASTER 2, the balloon guiding catheter was mandatory in both arms. And not a lot of people tend to remember that. So in ASTER 2, and I know that for a fact because, well, I was part of this, even if the randomization led to the combined approach, you had to use a balloon guiding catheter. So if you go long sheath aspiration stent retriever, I'm not saying it's a mistake. I'm not saying I never did it, but technically you're not following you're not following ASTER 2. You're not saying I'd go combine because ASTER 2 evaluated the combined approach and it's good. You're not doing this. And I would add something else. If you go with contact aspiration technique alone and you go with the long sheath, if contact aspiration works, that's good for you. But if it fails, what are you going to do? What the majority of physicians would do if contact aspiration fails in that setup is they would add a stent retriever. That's what I would do. I don't know about you guys, but that's what I would do. But if you do that, you're back to square one. You're back to going combined with the long sheath, which again, you're not supposed to do. Okay? So that's what I wanted to say about what is based on ASTER 2. And of course, if you go combined with the stent retriever and contact aspiration, you're having the same limitations as, well, going with stent retriever alone or going with contact aspiration alone. And that's why I think the BDAC has actually a place on the shelf. The BDAC is actually somewhere between a balloon guiding catheter, but that would go intracranially, or a contact aspiration catheter, but that alleviates the need for a balloon guiding catheter because the balloon is already on the BDAC. Now, I won't spend too much time on the characteristics because my colleague has already covered that perfectly. Let me just show you a couple of cases that we've done here at TOH. Case number 1, basilar artery occlusion. 78-year-old female, sudden onset of brainstem symptoms, basilar artery occlusion on the basilar artery. No TPA given. Patient goes to the angio suite. We use an 8 French sheath. We go into the right verts. Notice that the clot is basically mid-top third basilar. And this case was done by my friend and colleague, Dr. Drake. Dr. Brian Drake brings the BDAC all the way up to where the clot is. He inflates the balloon. As my colleague said, it's quite easy to see the mixture of 50-50 inflating the balloon. He pulls the catheter out. The basilar artery is recanalized. We do have, oops, sorry, I don't know what happened. We do have missing SCA branch on the left side, but the patient did so much better and was discharged 2 days later. So that's for posterior circulation. It works. That's the case I did now. Right M2 occlusion, 83-year-old female, unknown onset, so no TPA. As you can see here, the clot is clearly distal and in a branch that is too small for the BDAC. So I knew from the start I was not trying to do a contact aspiration BDAC technique here. I was trying to bring the BDAC and also use a stent retriever. Also, please notice that the vessels are pretty tortuous with a little angle at the innominate artery, as you can see here, and also several reverse curves on the intracranial ICA. So we brought the long sheath into the cervical ICA, and as you can see, there is a curve here, a loop here, and there is also 2 reverse curves in the intracranial carotid. And intracranially, the clot is right there with the arrow sign. So I tried to bring the BDAC over a microcatheter and a microwire. And what I noticed was that the BDAC was having a hard time taking those last few turns. I was unable to go all the way up intracranial. I thought, not a problem. I'm going to go get this with the stent retriever. And I'll try, just like you said, using the stent retriever as an anchor to try to bring the BDAC slightly higher. I was able to deploy the stent retriever in the occluded branch, and the BDAC got one turn higher than it was. But it was clearly far from the clot localization, and the branch was too small anyway. So I let the stent retriever there in place for 3 minutes. Then I inflated the balloon of the BDAC. I turned on the aspiration on the BDAC, and I brought back the stent retriever inside the BDAC. And I like to call this the Yoshi technique, because for the gamers among the people who might be there, and I don't see a lot of people recognizing the reference here, but Yoshi is basically a character in video games that is a little dinosaur that would swallow his enemies with his tongue. So I thought there was a good analogy here with the Yoshi. You'll see next year everybody will be using Yoshi at the next SNIS. The patient was recanalized, and the patient did well. So my early experience is the trackability is really good. The support is really good. And what I really like about it is that it leaves all the options on the table. So when I'm going for a stroke case with the BDAC, I can try to bring the BDAC all the way up and use the BDAC as an aspiration catheter. Whether or not the balloon inflation actually adds something is something that needs to be demonstrated, but it clearly doesn't hurt to keep that option on the table. If I'm going stent retriever, I can use it as the equivalence of a balloon guiding catheter, but that would leave intracranially instead of extracranially. I can go combine, just like my colleague just showed, or I can do Yoshi technique. You see, this is becoming a thing. I can do Yoshi technique. Yeah. So, what do we do with all this? As probably everyone in this room and around the table, I like science and I like data. I like to demonstrate that things work. So, a couple of cases that went fantastically well is, I think, not enough to clearly show that this tool is the future. So we designed a study called the Vanish study. Vanish is an acronym for evaluation of a new BDAC for stroke thrombectomy. And it's a single-arm observational study with a historical comparative cohort. So for those of you who don't know, Microvention recently got FDA approval for their stent retriever called the ERIC. And in order to obtain this approval, they used an observational non-randomized study with a historical cohort and with propensity score matching. And I know that because I'm the one who wrote that paper. And by the way, when they commissioned me to write that paper, they never told me that they were going to use it for FDA approval. And if I had known this, I would have charged more, by the way. But it looks like this kind of design is now accepted by the regulatory authorities. And I think that's good, because I don't think we should do a randomized trial for everything and anything. It would take too much time, money, and resources. But this is what Vanish consists in. Single-arm study of all consecutive stroke patients treated with a BDAC with pragmatic inclusion criteria. We will not exclude patients based on their age or aspects or clot localizations or vessel tortuosity, or you name it. We want to have real-world data, so we want to include everyone. And we use an independent core laboratory for the adjudication of all the efficacy and safety endpoints, and multiple studies have shown that we tend to overscore our own performance, and we're not blinded. Right? So we want someone who will be blinded to the treatment that was used to actually adjudicate the outcomes. The primary efficacy point I was just talking about, it would be the rate of first pass effects. And of course, we'll analyze all the other classic secondary outcomes, procedural complications, hemorrhagic transformation, clinical outcome, etc., etc. And we'll use a historical cohort of patients treated with stent retriever only, contact aspiration only, and combined approach. And we'll check if the BDAC actually outperforms absolutely everything else in terms of rate of first pass effect. The first couple of patients have been enrolled. The ones that I just showed you will be enrolled in Vanish. We hope to have answers, or at least preliminary data, within the next couple of months, and we'll of course share them with you. If you have a good practice and you're interested in joining that study, we would gladly discuss a collaboration, because the more people, the more fun, right? Thank you very much, everyone. Any question?